And thank you all for joining us today. We will be talking or addressing social drivers of health in the context of patient navigation. Next slide, please. I have no financial relationships to disclose, as well as I will not discuss any off-label use or investigational use in my presentation. Next slide. And so I share here with you our objectives for today for the presentation, We'll talk a little bit about Massey's catchment area, our community engagement infrastructure and aims, as well as an overview of Massey, our social determinants, our drivers of health navigation framework and model, as well as our patient navigators' role and workflow process, our outreach engagement to in-reach navigation, and as Dr. Nguyen mentioned, those meaningful community relationships. We'll also share a few of our challenges and opportunities, as well as a few impact testimonials and answer any questions you may have. Next slide. And so we first want to start off talking a little bit about Massey's community outreach and engagement, our catchment area. We actually cover a 66 county or locality catchment area or focus area, which is our target populations of medically underserved individuals. And of course, our goal is to decrease the cancer burden in those areas. And those are a lot of the areas that have some of our higher cancer mortality rates in the state of Virginia. As you can see, there are 3 of our locations that are here, which is in Tappahannock, Richmond, and South Hill. Next slide. From a cancer center perspective, we engage from the top of the organization with our philanthropic group, as you can see here, the Massey Nation. And then the director's cabinet, which is the committee who offers strategic direction to our cancer center director, Dr. Nguyen. We also have our coalition who works with our community outreach and engagement department or organization, and they are comprised of healthcare and education leaders. There are influencers across the catchment area or those target populations or focus areas that I just mentioned, our health district leaders, faith-based, tribal, and educational leaders. They offer insight about the cancer priority areas, help support our legislative and policy initiatives, and engage our MCC leaders on center-wide research, professional education, and catchment area initiatives. We also have our Champions program, who's a part of our COE as well, and they are engaging our communities in research and having the conversations about expanding, reframing, and focusing projects on the catchment area relevant cancers, priorities, and disparities. We use our community to bench model framework for that bi-directional communication from like our cabinet, our Massey Nation individuals, champions, and the coalition within our community, which creates our vision. And our community engagement team follows this strategic plan as outlined in the CCSG. Next slide, please. So I wanted to share with you our strategic priorities. We are focused on the 5 screenable cancers that are listed here in lung, breast, prostate, and the GI cancers, which is colorectal and cervical. And then we also work to reduce risk behaviors in tobacco, obesity, and then working in our survivorship program. So as a part of our strategic plan, these are our priorities and areas that we focus on in our 66 catchment area. Next slide, please. You could go back 1 slide. So we have 4 specific aims for the COE. However, we are here to talk about how we engage in our social drivers of health navigation, which is the focus of aim 2, through expanding screening and education outreach throughout the catchment area with the focus on the strategic priorities I just mentioned. And so our community to bench framework is a comprehensive cancer center. We have to be center-led. That's really important for us. We do this by providing community education and different screening initiatives, as well as health promotion interventions. One of those interventions, and we'll talk a little bit more about it in the next few slides, is our We Can Quit program. We actually have a community-based tobacco treatment specialist program, and those individuals work with our community, individuals out in the community, and conduct 5 counseling sessions, either face-to-face or via Zoom, to help those individuals stop smoking or vaping. They also work with one of our psychologists here to make sure if individuals need any, like a patch or anything like that, they can get the materials or products that they need. We also have our outreach and engagement navigation team members who are in the community setting to navigate individuals to screening, to care, and education and awareness to and about clinical trials. I will speak more about the role of these individuals in the next slide. Next slide, please. So to be center-led as a comprehensive cancer center, we have to be purposeful in our engagement when we're in communities. So, it's important to us to not just go out into the community and pass out flyers to individuals talking about getting screenings, the importance of screening and education on different cancers or prevention, but we prioritize and promote cancer education and screening through facilitating research and providing the education that I mentioned on the importance of clinical trials. But we do all of this through relationship building with our community partners. We're committed to community service and outreach activities related to cancer prevention and control. In our COE team, we have a group of 9 individuals. With that, we have outreach and engagement team members, as well as patient navigators or social drivers of health navigators who are working out in our community setting, as well as in reach. And I'll talk a little bit more about that in the next few slides. But our outreach team is embedded in the community. They're not just in the 4 walls of the cancer center. They're out in, for example, in the libraries, as well as the federally qualified health centers out in those communities where there are higher cancer mortality rates. Next slide. And to have purposeful engagement, we have to follow a framework. So we have a multimodal and multi-skilled navigation team structure that comprises of nurse navigators, our social workers, as well as our non-clinical professionals, which are our outreach and engagement team members, as well as our SDOH navigators. And the goal is for them to identify, address, and sustain those social drivers of health barriers. So it's important for those team members, for instance, our community health worker navigator, I mentioned earlier, is bedded in the community for outreach, building trust in a grassroots approach, creating partnerships. We have 3 actual research centers out in the community. And so they are there on a weekly or daily basis, making sure that they're connecting with our community and community partners. Our in-reach approach to navigation is where we have an in-reach or navigator, SDOH navigator, who works with the nurse navigator, along with the social worker and our clinical trials office and team. Next slide, please. So our outreach to in-reach social determinants of health navigation program is a huge part of our efforts is in the community, developing those partnerships and building relationships. We've been in the community for a long period of time, building the relationships. And, I'd like to give an example of that. So for instance, we have partnered with the local library in one of our high cancer mortality rate counties. We have created an office space. We have our outreach engagement coordinator who's there a minimum of 3 days a week, who works out of that office, who is meeting with individuals to provide the cancer education and awareness. They are also working with our FQHCs and community partners out there to provide education and make referrals into navigation. They also make sure that they're, again, creating those partnerships, setting up appointments for screenings, ensuring that the individual or that client is getting the follow-up care. They're providing that emotional support and working with the community health worker navigator, who is also doing that SDOH assessment and referring the individual to support services. One of the things that's really important is having the open communication regularly with your navigation team, so that outreach and engagement individual is working to communicate with the community health worker navigator who's out in the community, as well as making sure the communication when individuals are coming into the health system is happening through the in-reach navigation approach. And so with the in-reach navigation, there are partnerships that are being developed, but it's more on the side of the healthcare team with the nurse, the social worker, the provider, and the new patient coordinator. As a part of that, the management of the nurse navigators, as well as myself as the SDOH navigator lead and social worker have been meeting and continue to meet on a weekly basis to talk about any, how we can collaborate more to make sure everyone's on the same page. A lot of the focus is, of course, as I mentioned, on those underserved populations and the screenable cancers. And so to make sure that the team is integrated into the health system, they attend daily huddles, the navigators, along with the social worker, the nurse navigator, weekly tumor boards. And then there are also meetings amongst the team to make sure that we're all sharing the information that's needed. They connect with the patients, they meaning the navigator is with the patient during the visit and or following up with phone calls based on whatever that patient's needs are based on their social determinants of health. One thing that's really important and that all team members work to do is documenting a summary in the electronic health record. That's what we use to ensure that everyone understands what type of care that patient is receiving. So from the community health worker navigator, the patients coming over into the health system, they are ensuring that they document in the health record, as well as the navigator that is actually placed into in the hospital system or health system. I did want to mention here that all of our staff are trained. They are actually cross-trained. So for instance, unfortunately, because of health reasons or people go out on FMLA, we want to make sure that the work doesn't stop, that we can still connect with our community partners and provide those services. So we ensure that our outreach and engagement individual is trained navigation, the community health worker and go in the hospital setting and vice versa. An example of that would be, I have one of my navigators who works specifically in the clinical trial space, ensuring that individuals are getting on trial, who once or twice a week goes out into the community and works at one of our resource centers to work with the FQHC there, as well as, the library and meet patients there, and also works to do the We Can Quit program in the community where he is having those sessions with individuals at the community level. Next slide, please. And so I just wanted to share this process with you to show what the model looks like for us for outreach from the community on to reach into the health system. We have our outreach team members in the community providing education and awareness, as well as we have a few cancer prevention services. I mentioned the We Can Quit. Another service that we offer is We Can Eat Well. And that is actually an RD program who works with a registered dietitian who works with the outreach and engagement team members and assists with grocery store tours to talk to individuals, clients, and or our patients about eating healthier. And we will eventually offer group classes. We also have We Can Take Action, which is more of a prevention, a risk reduction planning out in the community. And we have a social determinants of health navigator who is actually a nurse on our team who will conduct these assessments or conversations with the individual about screening, cancer screening. So it's done in like 10-year increments, talking about, have you had your mammogram? Do you know what the purpose of getting a colonoscopy is? So having those type conversations to get individuals out in the community into screening. And then our navigators are in the primary setting along with our outreach and engagement team members. We work closely with those FQHCs, charitable centers, as well as, again, we're in one of the libraries in one of our higher cancer mortality rate areas. So our goal is to get individuals to screening. If they go on to get diagnosed, there is an in-reach navigator who is with that individual throughout the entire process and making sure that they are aware of the possibility, if needed, of clinical trials. And one partner I did not mention is we also work closely with our churches as well in the specific areas or different areas. Next slide. And so I wanted to share with you the importance of having those meaningful community relationships. And actually I should have switched this slide to show that the Project Coalesce was a project that we did to implement a quality improvement initiative with some of the FQHCs in South Central Virginia. The purpose was to identify and address race-related barriers to cervical and colorectal screening. It was instrumental in elevating the community's voice, increasing community support, and ensuring that the community, had the screening knowledge about colorectal screenings and cervical screenings. With that project, we wanted to make sure that this was not just, a one and done. You do this project for a year or two, how do you sustain that? So Dr. Nguyen and the leadership team came up with the idea of our community seed grants. And those initiatives helped those community partners to expand the programs that are focused on promotion of health equity, the person-centered care across the cancer continuum from prevention to survivorship, and reduce suffering in the 66 county catchment area. The seed grants would help bridge the gap in our communities by allowing both new and experienced grant-funded individuals to work side by side with our cancer center and continue the work that we're doing. Because we have such a small team, and because we have such a large catchment area, our community partners are the ones who can help us continue to work out in the community and get to those individuals to make sure that they're getting the screenings that they need. And so with that, for the first 2 years, there were community seed grants that were provided to a total, I believe it was 13 individuals or organizations. And now we're going into our grant process where we received, I believe, 8 applicants, and we will choose 2 individuals, and it's a larger grant amount that they would receive to continue the work in the catchment area. So the goal was, Massey wanted to make sure that and Dr. Wynn and our team that, we're making measurable gains on colorectal cancer and cervical cancer disparities, and increase screenings by 5 to 10% to improve diagnostic follow-up, in these areas. Next slide. So, with all the things that we're doing as an organization, as a community outreach and engagement department, and the priorities that we focus on, of course, that does not go without some challenges. Again, I mentioned we do have a small team, so making sure that everyone understands like what the community engagement and navigation team includes, what their roles are, how we can integrate them into the health system. Also, because we have such a small team, I talked about the team being cross-trained, ensuring that everyone, we can use the outreach team in reach inside the health system or vice versa, and workforce development, because as you know, since COVID, there are a lot of individuals who prefer maybe to work in an environment where it's more remote. And that's not always the case, depending on the work that needs to be done. In order to create those meaningful partnerships and be community focused, we've got to be in the community where the people are, having those face-to-face conversations, building those relationships, understanding what their needs are, what they need from us, versus us just believing, oh, well, this is what we need to do to remove these barriers or cancer mortality rates. So we are lucky here at Massey to have the support of course, our leadership and Dr. Wynn and his commitment to ensuring our COE activities, there's funding, and because of our Cancer Center grant, supplement grant, that the COE, team, there's a budget for COE and the team to be able to go out and create that community to bench model. So it's important that you have the buy-in from your senior leadership and the community so that they can help sustain the programs and efforts. Lastly, I just wanted to share a few success stories. So next slide, please. Of the work that we're doing out in the community, our outreach and engagement navigation through our We Can Quit. We had a participant one of our participants who shared, that they had started smoking at the age of 14 and how they tried to quit smoking in the past, but they always went back to it. And their quit coach, again, that individual meets with this person out in the community, meet them where they are, or if it's, the individual wants to meet via Zoom, they have those conversations and talk about the concerns that they have, and also if they need a patch or whatever the case may be. So the quit coach was, just as excited and engaged in the conversation with that client. And then there are two testimonials from individuals who have worked with the navigators in the health system and how they appreciated their guidance and assistance. And, if they weren't available to assist them, getting to their appointments would be a challenge and they wouldn't be able to continue treatment. So I think it's important to also, to report how impactful the experiences are that the navigators, how they lessen the patient's feeling overwhelmed and increase their confidence level when they're speaking with the care team. They empower them to have a voice. And then how the patients or clients report their experience with Massey's care team, how it exceeds their expectations and the relationship that they've established with the navigator. That is all that I have for you today. Now we can take any questions you may have about the presentations or any questions in general about our navigation program.
Thank you, Tiffany, for such an amazing, informative presentation. I'm going to start with some questions that we have in the question and answer part of our screen. So if you have any questions, please make sure that you put them in the question and answer feature, and we will pull them from there. So the first question is, what training are Massey patient navigators required to complete? And should there, in your opinion, be a standard best practice that applies to all navigation services?
So yes, thank you, Dr. Wright, for your question. All of our staff members, our outreach and engagement, as well as our patient navigators, when they're onboarding, have training. They are required, one of the requirements is the George Washington University Patient Navigator Training, along with motivational interviewing, as well as if those individuals who are not tobacco treatment specialists, they have a specific training, but those that are not, they also do a tobacco training because that's one of our, risk behaviors. So we want to reduce that. And then they also are required from onboarding to do the city training for research. We also have the nurse navigator who I mentioned, who does a lot of the education on a monthly basis during our monthly meetings, have different trainings. And then our teams are encouraged to, as webinars become available related to their roles, they are encouraged to do those trainings. So we provide that information, they share it amongst the team. So training is ongoing, but there are a few trainings, as I mentioned earlier, that are required. Yes, I think there should be a standard for training for all individuals, like working out in the community as well as in the hospital setting, just in general for navigation. So yes.
What are the greatest challenges for patient navigations, and how are they addressed?
So I think the greatest challenge for patient navigation would be just ensuring that everyone understands their role and how they have to connect with other team members. It's not a one-person show. You have to be able to communicate effectively, to be the voice for your patient, as well as ensuring that your teammates are kept in the loop about what's going on for that individual as well. I do have Dr. Debbie Bryant here on the call. I'd like her to chime in with that response, if that's okay, from a COE executive leader perspective.
Hello, Dr. Bryant. Would you like to introduce yourself and then provide a little bit more on this question?
Let me unmute. And I know my name turns up as Tiffany on the box, on my little box. So I'm Debbie Bryan. I'm a nurse. So I come from a nursing background. I was a retired associate professor in a college of nursing and another institution before coming here to Massey Cancer Center. So I've been engaged and involved in patient navigation for a long time, and I've done some publications and writing in that area as well. So I 100% agree that oftentimes in the healthcare system world, people do not see the navigator role as a professional role. Some just believe that a peer-to-peer counseling role will suffice. I disagree with that. Because I think you do need training to make sure that the role of a nurse navigator, social work navigator, or patient navigator, that they are not, that everyone kind of stays in their lane, but the communication happens across those professional areas, and that we have folks or our professional understanding of what navigators need to understand and know to be in a place to translate information to clients back and forth. I also believe that the role of the education role as it relates to navigation and social drivers and removing barriers to care is so important, that we really have an understanding and we respect the navigator's role to be able to do that. I'm not sure I answered everything, but I think I gave it a good start. But certainly happy to help answer any other questions or provide context.
So our next question is gonna go back to that training piece, Dr. Brian and Tiffany. How do you introduce your programs to the VCU Massey clinical faculty, including new faculty and residents?
You want me to take it, Tiffany, or you? No, you. I'm sorry.
Mhm. Yes. Mhm.
Well, I think that's not a one and done, right? First of all, it takes time to get the respect for a program within an institution when you're first coming in. So you're respected as the professional. You share and really build the relationship with the clinical team that's on staff, or it's been there a long time, whether they have or haven't been engaged in navigation for a while, right? So that takes time to build that trusted relationship with your colleagues, that they respect what you're doing, they see what you're doing, they believe in the value of what you're doing, and that it's making a difference. From that perspective, honestly, I think that work kind of happens organically, and it continues because they know who you are, they know the team, they understand what you're doing, and so it just kind of reverberates from that point. And you don't have to do so much of constantly training, but people are looking for you, or they understand the value of what you're doing over time. So it takes time as anything else.
Yeah, it takes time, and then also having, as I mentioned, the managers connected, social work. I work with the nurse navigator manager. We meet on a weekly basis just to talk about best practices, any challenges that the team members may be facing, and then making sure that the team members and or managers are talking at the tumor boards, or the providers have, monthly meetings, just sharing the information about the importance of the support of the navigator to the team. So that's how we've kind of made sure that, we share information about who we are, what we're doing, and how we're all working collaboratively.
And if I could also add to that, we also have the respect of our colleagues understanding and knowing if something is not going right, where they should go, right? If they believe something is not quite fair with a navigator, somebody missed a point, something happened, they have the respect for Tiffany and I, that they know that they can come to us and we can have a conversation. And then we can have that conversation with our navigation team as well. And this is also, we live internal to the brick and mortar, but we also live external into the catchment and the community area that we serve. And all of those things have to work in concert so that we can keep these collaborations moving. We can share and talk or develop our model with our partners who are providing that kind of primary care systems that's outside of the brick and mortar in the healthcare system. So cancer and the prevention of cancer, right, in a navigation model is as important, I do believe, as what the model looks like that's internal to our brick and mortar health system of when someone is diagnosed with cancer and moving them through that continuum. So that's why we have really been working hard to build our program that meets the needs of both of those systems together.
So what I'm hearing, it sounds like it's a constant engagement or a constant contact. You're having these monthly meetings with the providers and the faculty members at VCU to keep them in touch and in tune with what's happening on the navigation side. But you're also having that constant connection, that weekly connection with your navigators, so that it's a bi-directional communication, and the clinicians know what's going on, the residents know what's going on, and your navigators. So it's never something new, right? And the relationship is already there. And so they are more open to hearing and receiving your new programs as you introduce them, because that relationship is already built.
Yes.
I think you got it.
Yep.
All right. So are the navigators' positions funded by the hospital budget or grant? wondering what techniques your center uses to keep salaries sustainable.
I think I made a decision to come to Massey Cancer Center because of the commitment from Dr. Robert Nguyen. I had never in my career before had an opportunity to work with a cancer center director who is leading the service line internal to the organization and the research that this is what we will do. Not when we receive grant funding, but this is what we will do all the time. So there are those within the organization system, the healthcare system teams that we, Tiffani and I, who are on the VCU Massey Cancer Center side of the house, work with, that they are funded by the hospital, correct? However, for the COE and the full scope navigation, we are also funded and committed from the budget of the cancer center. So I think you need all things and everything that you can to make it work. If we get grant funding, it's great, but if we don't, it's not going to go away. That is the commitment from our leader. And it takes that strong commitment. And again, for the first time in my career, I'm proud to be a part of the team that he has committed those resources to ensure that this happens.
Okay, so I'm gonna switch.
I was just gonna say proud of you too, but then I was trying to, not say anything, but I'm gonna go off mic now.
So we're going to switch it a little bit to talk about electronic medical records and how we integrate that into the Massey navigation services. This is a question that's kind of come up during some of our monthly meetings about how we use the module for social drivers of health within the navigation services. So could you just address how we are effectively integrating EMR into our navigation services and utilizing that module specific to Epic? Although all of the partners are not using Epic,
Okay.
Massey Cancer Center and the health system does use Epic. So this response will be related to the utilization of Epic.
Absolutely. So that should have been one of the trainings I mentioned when we talked about training. That is definitely one of the requirements for the navigators. They get the Epic training, and then they also, in our Epic system, we have a social drivers or determinants of health template where there's specific questions that are asked. And when the nurse navigator typically meets with the patient for the first time, they are the ones who are working to complete that SDOH questions. But because we have so many patients and we focus on the screenable cancers, our patient navigators work in conjunction with our social workers to complete that social drivers of health questionnaire with every patient that they work with. And so that drives and helps us understand, what are the needs of that individual, be it if they're just coming in for their appointments or they're on a clinical trial. So we do utilize that Epic social determinants of health template, and the training for it is called Healthy Planet in Epic. So all of our team members get that when they're onboarding to ensure they can document as well as utilize that template to ask questions or ask those questions, assessment to ask the questions that they need for each of their patients that they work with.
Can I go back and add one other thing?
Mm-hmm.
I think this is also when we have to really expand the way we think about this, because it's not only a patient in an Epic system. This is also about clients and the individuals that we talk to, connect with, have conversation with, help them set goals for themselves and think about motivation long before they ever need us in a cancer world, right? We have to be able to do a better job of normalizing these conversations about what cancer prevention looks like, what it really means to be a part of a screening trial or an interventional trial if I get cancer. So a full scope, social drivers, removing barriers, navigation, outreach, engagement model does both of those things. So I wouldn't want anyone to get bogged down into what does it look like in Epic? Because my question would be, what does it look like without Epic? What does it look like? Because these are, again, the individual clients, and we need to really work on having these conversations and talking about this long before they need us in a cancer space, right? I think that's really important to what I hope we start moving these conversations toward. If we are really going to talk about and removing and thinking about this in alleviating the world of health of disparities, this isn't all about someone who has cancer. This is about before that cancer, which is another thing that Dr. Nguyen, since we're talking, has been, you know, he's beating that drum over and over. This is a bench to community, and community in our communities. We need to start and talk about these conversations long before it's cancer. So thank you for that.
So one more question. What gaps have you identified in the navigation continuum? And how do you think we could improve coordination of care among and between medical and social service personnel? So now we're focusing on that navigation continuum and where those gaps are between the medical professional and the social services.
That there is a gap.
Surprise.
The chasm is actually quite wide, right? So this is the group that has to be able to at least to identify and know that there is a chasm. And unless we start working to decrease it, it will continue to grow rather than lessen. So how do we do it? We do it by building a full scope system and model. We do it by pushing ourselves beyond where we are today. We push ourselves to talk about prevention, screening, conversations, relationships, trust, who, where, what, when, how, why, and find those priorities that make sense for your area and your center, and how do we build that? But it's there, no doubt, it's there. We talked about and I think there are probably a lot of people on this call that says our team is not as small as we think, or we suggest, because I've been engaged and involved in smaller teams for, of course, a number of times in my career. And so to some, we're probably not as small. To some, we are probably too small. But to just know that you've got to be able to look up, look out, look around, and not just in a one scope dimension to be able to lessen that chasm.
Okay, so I'm going to circle back to a question regarding our interactions with the providers. I'm assuming that there is some training that's taking place between our navigation services and our providers regarding what navigation services we offer and how to interface with the care coordination of these services. How do you guys go about doing that? Is there a training that you've put together to train your providers? Is this an online or a learning management system? How is that done? Is this just through, do we have a standard course that's offered through Canvas? How are you actually engaging with your providers outside of just a standard meeting to keep them informed about the services?
Tiffany, do you have a specific answer to that?
So no, we don't have a specific training, related to navigation for our providers. This is where we do a lot of, presentations, talk about what our role is, what the expectations of the navigator is, and how they can support the team. That is something we would, look to do towards in the future for providers, but currently we don't have a specific training, related to navigation. A lot of it is presentation based, making those presentations, doing their monthly meetings, provider meetings as a whole or as a team.
So do you, oh, I'm sorry.
So what I would add to that is, I think that the goal would be that we have been trying to do is continuing to do a good job, and they look for us, right? If we have our oncologists, our team, the systems that's been in here, had been in place for a long time before Dr. Wing came to the organization. And so we just kind of go in and keep working at it. And they literally said, that's a good program. I want to know more about it. Can you come and can you talk? Or my goodness, here, my patient knew something because they were engaged with navigation. I've had a couple of providers call me and say, I want that person, one of those navigators that you have, I want them on my team all the time. So the goal is that we're here to be a part of solving and making things better. And as long as we're continuing on that path, we will continue to be invited to more tables, and we will, those training and opportunities will continue to present themselves.
Yes, and we also make sure every day of the week, there are navigators in the health system, sitting with the providers or the nurses in their areas, so that they show, see that they're available, and to learn more about, well, hey, I need this done. Is that something you can help with, even if they're not sure? So making sure that the navigators are actually visible and in this setting where the providers and their teams are, has been something that has been very instrumental in our success, in individuals wanting to know more about navigation, and also, hey, I need your help with this.
So it sounds like if you had to narrow it down to two things, your most effective ways for engagement is having those navigators be seen within the health system and maintaining that constant communication between yourself, the program, and the providers.
Absolutely, yes.
So we have about
translate for us all the time.
So we have about 4 minutes remaining on our session today. I have one more question that we have in the question and answer, but I'm going to save that for the end. But I wanted to give you an opportunity to be able to close out within the next 4 minutes. Anything that you wanted to add before we close our webinar for today?
I just want to thank you all for the time and your opportunity, your questions that you've had. I'm happy to speak with anyone offline if need be. We are here to help. So please, Dr. Wright and Atora has my information. Please feel free to reach out. But thank you for your time today.
I will just add, I think I feel blessed to work with a team and with leaders, and a leader, Dr. Rob Wynn, who says he is unapologetic about what we need to do and what we will do. And he continues to push us to bigger, better, greater, and moving positively. Sometimes it's tough. Yes, we all know that. But there are those days when you look up and you're like, oh yeah, we did good today, right? So, you have to have the courage to ask for your leaders to do the same. Let's do what we know we need to do, that the literature supports. There's no question on where we should be, but now the answer is, how do we get there? So thank you.
Well, I would like to thank both of you for your time today. Again, this was an amazing webinar, and thank you for providing us with insight regarding how Massey is leading our charge for navigation services.